Good morning. I think people will continue to filter in. There was a long queue at the gatehouse to get into the parking lot this morning. And it's my great pleasure to be able to introduce this morning's Grand Round speaker. I'm Steve Finn, head of the Division of General Internal Medicine. And our speaker this morning is our annual honor lecturer in the division for the Roger E. Pecoraro Lectureship, which is our annual memorial lectureship for Dr. Pecoraro, who was one of the founding members of our division, and this is the 26th annual event. And I'm particularly gratified to introduce this morning's speaker, Dr. Ebony Boulware. And I should note that not only has Dr. Boulware been invited by the Division of General Internal Medicine for this event, but also by the Department of Medicine Committee on Diversity and the Center for Equity, Diversity, and Inclusion in the medical school. And so we're all very pleased. Dr. Boulware is a distinguished professor of medicine from Duke. She received her undergraduate degree from Vassar Medical School at Duke, house staff training and chief residency at the University of Maryland, and fellowship training and an MPH degree from Hopkins, where she remained on the faculty for 11 years before assuming her current job, which is chief of the Division of Medicine at Duke, as well as being director of their CTSA and head of their Clinical Translational Science Institute at Duke. She is a very prolific researcher with well over 100 publications in highly regarded peer-reviewed journals and a continuous funding from a variety of sources, including several institutes at NIH, the National Kidney Foundation, and PCORI, as well as other sources. She has a very prominent national presence. She chairs the advisory committee for the Robert Wood Johnson Clinical Scholars Program, sits on several study sections, and is very active in several national journals. And it's a real privilege to have her as our speaker this year. And she'll be speaking to us about organizational literacy. So, Dr. Boulware, thanks very much.
Can you hear me? Am I live with my mic? All right. Good morning. Thank you so much for that wonderful invitation, and thank you so much for having me. It's really an honor to be here and a pleasure to get to speak to you this morning. My talk is really going to be talking about how we can achieve improved healthcare by thinking about the concept of health literacy. And so what I want to talk about is health literacy in a way that we think about it throughout our entire healthcare delivery context, not just in terms of helping patients read or speak with us, but more in terms of our overall healthcare delivery model. I'd like to share with you some emerging models to improve health system health literacy, talk a little bit about some of the challenges and promises that thinking about health literacy in terms of how we deliver all of our healthcare presents, and then give us a call to action. Since this is medical grand rounds, I like to start with a patient case, or in this case, it's a patient story. And this is a 55-year-old African-American male in Baltimore, Maryland, with end-stage kidney disease. He began hemodialysis a year prior to this story, but was interested in a kidney transplant. Prior to his dialysis, he had been under the care of a number of caring healthcare professionals, including a nephrologist, for 2 years, and he'd had gradually declining kidney function. Although he was in care, he still experienced a crash start on hemodialysis. In other words, he was in care and then suddenly got cold-like symptoms and then started urgently with hemodialysis in the emergency room. I see some nodding heads because this is a common scenario that we frequently see. And although he wanted a kidney transplant, he'd actually had very little time to think about transplant or how he would even get that, or even his hemodialysis prior to this crash start. And here's what this patient said. These are actually his own words from an interview. And we asked him, what did you know about your treatment when you arrived at the emergency room? And these are his words. He said, quote, I didn't know anything about it. I just did what they told me. I didn't even know what the catheter was for. And the nurse said, she says, do you understand? And I says, well, they had the thing in my side first, the access thing, before they put the catheter in. No, I didn't know anything. So what's happened here? I've just said a story. We've all several people have shaken their heads. It's a common scenario. What's the problem here? Is it that the patient has a poor understanding of his disease and it's really either a knowledge issue or just that he doesn't understand? Clearly somebody along the lines of the care had been talking to him about his disease, and undoubtedly some of these discussions aspects must have come out. But was it a failure of the patient and physician or the patient and healthcare provider's communication? Was the communication actually effective? Was there a failure of the provider to actually deliver the right kinds of information? Were there system processes involved that got in the way of this patient understanding his treatment options and having a smoother transition to this treatment? Was it something else? So with those questions in mind, I want to talk about the concept of health literacy and what it means to have to be health literate. And there, full disclosure, I am not a scholar in this area, but I apply these concepts in my own work. And I think thinking about how to apply these in our care and our work, whether it be our clinical care, our education of students, or research, thinking about how to build in health literacy in academic medicine and in care delivery is very important. So today we're talking about in care delivery. So health literacy has been defined as the degree to which individuals have the capacity to obtain, communicate, process, and understand basic health information and services needed to make appropriate health decisions. And that's a critical component. And it's not just that people understand us, it's that they understand us enough to be empowered to make decisions that are aligned with what they would like to happen with their health and with their care. It's influenced not only by that individual patient's capacity, but also by their provider's skills to communicate and the system's demands and complexities and the capacity of the system to help empower patients to make appropriate health decisions. And the idea is to help patients make sense of health information and services, and we know there are just myriad health information and services that patients need to sort through, no matter what they're confronting in the healthcare system. And also helping providers convey information and services to consumers. So what types of health literacy skills do patients need? Patients need to be able to find information. They need to be able to communicate what they need and the services that they need. They need to be able to obtain those services as well. They need to understand the meaning and usefulness of services that we have available to them. They need to be able to consider the choices that they have available to them and the consequences of their choices and decisions. They need to be empowered to decide which information and treatment options align with their personal values, what's going to get them to the goal that they're looking for in the future, and make informed decisions and act. We as providers need another set of skills. We need skills that help patients or people find information and services. We need to know how to communicate about health and healthcare in effective terms that translate well to patients and families and other consumers of healthcare. We need to be able to help people process what they're explicitly and implicitly asking for. So people may come to us with certain questions, but there may be other embedded questions that they haven't asked that we also need to be able to anticipate that they have or may have concerns about and fill in some of those holes. Understanding how to provide useful information and services. Perhaps it's not always giving a sheet of paper that has a listing of something, but sometimes it's a different forms of communication or different ways of demonstrating how to provide services. And deciding which information and services are appropriate for a specific person in their specific context so that they can act. So there's a concept of a health literate organization, and the concept that's been proposed, and there's actually been an Institute of Medicine roundtable on this, and this was in 2012, so we're getting pretty far along in this movement, thinking about how healthcare organizations can become health literate. But the concept is that the whole organization could remove barriers and recognize some key potential challenges that need to be overcome if we're going to deliver comprehensive care that allows patients to be fully enabled in making decisions. So first, a health literate healthcare organization is one that recognizes that miscommunication is very common and that it negatively affects patient care. So it's constantly thinking about how to overcome miscommunication. That miscommunication can arrive in a variety of clinical to operational situations where patients or families interact with healthcare in a variety of different ways, whether that be at the front desk, whether that be with finance, whether that be with the actual clinical care, so the whole system. Individuals who ordinarily have very adequate health literacy, so they may be very well educated, they may even have a very complex, they may be healthcare providers, can even have difficulty in processing and using health information when they're sick, frightened, or impaired. And that's very important because it means that as we communicate with people, we really have to take into account the specialized context with which we're interacting with them because they need us for healthcare delivery services. And then further, literacy, language, and culture are intertwined and linked to cultural competency and health equity. I bolded this because I think this is a really complex concept in that when we're talking about how to communicate well with consumers of healthcare, patients, families, anybody who's coming in contact, we talk about a variety of different concepts, cultural competency, we talk about health equity, we talk about these, and they're actually all embedded. It's how are we providing care that people can relate to, that's applicable to them, that's appropriate for them, that empowers them to make decisions that are aligned for them. So these are all linked concepts. And I would argue that until we can get that right, we won't really be able to achieve health equity because we'll have people engaging with the health system in varying levels of effectiveness. So I wanted to just share with you some of what this roundtable from the Institute of Medicine came up with 10 years ago, or not 10 years ago, excuse me, I'm going forward in light speed, 4 years ago. 4 years ago. But they came up with 10 attributes of a healthcare organization that would qualify an organization for being a health literate organization. And I'm going to list these and then go through some examples of each. I won't dwell too much time on it because I have a lot of information to show, but I wanted to I think it shows the breadth of what a healthcare organization could do if it was going to prime itself to become a health literate organization. First, leadership. The idea that the entire organization would take this on as an important focus, and then it would start at the top, and that groups, varying levels of leadership, all the way down to the smallest clinic or setting, all the way up to the very highest level, would take on health organizational literacy as something important to grab onto. So it would create a full culture change. And that would mean integration of activities around organizational health literacy into planning, evaluation, and the quality improvement activities that an organization takes on, helping to prepare our entire workforce, as I mentioned, from the front desk staff to the clinical providers to the billing to all systems to be able to deal with health literacy. Evaluating services and information that we provide across the board to make sure that we're meeting patients' needs and the patients of all. Communicating effectively, ensuring that healthcare is accessible, designing easy-to-use materials, addressing health literacy in high-risk situations like informed consent situations, and explaining coverage and costs. Often we're providing healthcare services and somebody's going along with us, yes, 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 and then they get to the point where they actually need to pay for that medication or that service, and it's no, because that doesn't align with what I'm capable of doing. So really, this comprehensive way of thinking about what we're delivering, what we're trying to do, and that more broad picture. I've mentioned this, and I'm going to just touch on some key points on each of these 10 points and then move us along. But leadership would mean that the ideas about how to incorporate health literacy would not just be limited to a few projects or a few programs, but that it would be something that in all of our operations decisions we'd be thinking about who's the receiver of this and how can we improve this to help move the organization forward. Establishing a culture of language, expectations, and behavior, and implementing evidence-based strategies to develop and test new ones. And so that would include allocating of resources, how you allocate resources, how you cultivate organizational champions for health literacy. Integrating it into the planning, evaluation, and quality improvement. I'm sure here, as with everywhere else, there are lots of quality improvement and planning activities going on. And how do we work in our patient and our provider and our families' perspectives into that, making sure that we're communicating what we're trying to do effectively and ensuring that people are getting what they need. Doing rigorous program evaluations and tracking and reporting communication failures and doing root cause analyses. When we talk about preparing a workforce to be health literate, this is where it becomes important that our workforce is diverse and has some understanding of the diversity of our patients and families coming from the communities that we're actually serving. Incorporating health literacy, and I'd say the same concepts, cultural competence, into orientation sessions and augmenting in-house training. We would talk about clinical training, it even becomes important as well as we train new medical students, residents, and thinking about how we work these concepts in. We increasingly see education training, but thinking about the full complement of what we do as healthcare providers in terms of communicating with patients and families, the information we're giving to them, how we ensure that our communication is effective, should begin to become an integral part of the education that we're doing in the context of training. Including populations served by our information in the design and implementation and evaluation. Last night I was giving a discussion, we were having a discussion about how to incorporate patients, families, healthcare providers, other stakeholders, people who care about the end result, into the process of changing our clinical care. So what's recommended is that we develop advisory groups that involve individuals not only with limited health literacy or different perspectives on engaging with the healthcare system, perhaps from different cultures with different language capacity or ability, as well as adult educators and experts in health literacy as we begin to design systems to help our communication function. And collaborating with the community as well to develop community appropriate and culturally appropriate approaches for your local area. Avoiding the concept of stigmatization. I think communication making communication readily accessible does not mean dumbing it down. It means bringing it to a level where we're actually speaking the same language. And I think that's an important distinction, that when we talk about limited health literacy, it's not just people who may or may not be able to read or speak a language. There's actually a commonality in how we communicate with people that makes it accessible. Using less jargon, for example, thinking about how we communicate what we're trying to do in common terms that everybody can understand. Streamlining information collection and not overwhelming people with the amount of information we give them at certain time points, having it be readily digestible, and getting down to those common issues that actually get in the way of healthcare delivery, like can you pay for medicines, or do you need assistance with the care that we're recommending? Thinking about, as well, of course, the quality of the written information that we're giving or how we communicate information through video or through additional types of media. A culture that emphasizes verification of every communication. I could just offer, many of us have these personal anecdotes. I, as a clinician, go in and I took my mother, who's a physician, in for heart surgery, and we came out, and at the end we have a note, a list of instructions. And between the two of us, we're having a difficulty figuring out, okay, when's the follow-up appointment? Let's look at this long list of medications that you have, and when are you going to take this, when are you going to take that? And it takes me 30, 40 minutes to sort out all the pills and do it day by day. This is complicated stuff, even for people who've spent their life in this system. So how do we really begin to verify that people know what we're asking them to do? How do we ensure that we're doing it in a way that makes sense? Can we simplify it a bit? Allowing adequate time for all interactions, We know time is always of the essence, and we have to be very cognizant of how, when we're really trying to be efficient and get things done, are we really effective at the same time? Using technology to facilitate communications, and treating communication failure as a safety issue. With the same care that we want to make sure that a patient doesn't get assigned the wrong information, we want to use that same care in how we communicate the right information, that these are all linked in terms of safety. Navigation and assistance is very important. Again, I give you an example of myself trying to navigate the healthcare system, and in a system that I actually work, and how difficult that is. When you come from outside of a system, imagine how much more difficult that is. So again, thinking about how do we navigate people through a very complex forest of services that we're offering. It's almost like being in a different land when you come into the healthcare system. All of a sudden, you need a whole another set of directives and maps to get yourself around. And so this concept of navigating people. We've talked a lot about, I think, this providing print, audio, visual, and social media content that's easy to understand and act on. This is probably one of the lowest hanging fruit where we can work on, where we do give people a lot of information, and just thinking about how is that information going to be interpreted, where are the pitfalls, where we provide some recommendations. Where can a person get tripped up in that? Where can there be miscommunications? There was an interesting example I read in a toolkit that I'm going to show you a little bit later, where they talked about the physician talking about a local remedy around a wound maybe not being effective. And the patient took that to mean, I may have to travel to a distance to get my wound cared for. But the physician was just talking about, should I put a local treatment on the skin, actually around the wound? So even the terms local, these basic terms don't have the same meaning in two different people's perspective. Obviously, these ideas of transitions, the example I gave in my personal example is an example of a transition of care from in-hospital, out of hospital, and these become very challenging to navigate. Thinking about how to have people have aids, pill boxes, pill cards to remind them, and confirming understanding about hospital stays. I honestly will say, if somebody comes out of the hospital, they're glad to get out of there, but that is one of the most stressful time periods a person can be in. You're really thinking, the family's thinking about so many different things to get their family member out of the hospital. It truly is one of the most daunting time periods to go through, and we don't provide a lot of support during those transitions, and this is an area that we really can focus on. And then I think this concept of payment, again, and the finances of healthcare is very important. And we as healthcare providers don't often, we're increasingly becoming aware of this as an important issue, but the social determinants of health really are big determinants of health and effectiveness of healthcare. So thinking about how we communicate costs of care in advance, that people are familiar with the costs of their care, and what it will take to engage in a treatment that we prescribe. And us as healthcare providers becoming more aware of the complexities of healthcare delivery and payment. Okay, so I'm trying to advance. Oh, here we go. So this task is daunting. How do we implement? Fortunately, there are many best practices out there, and I think the task is daunting. There's a lot for us to do in healthcare. But we already have a lot of developing tools. I'm going to share some with you. But just to name a few, there certainly are many more health literate materials coming into availability that people are developing within healthcare and also on the market that we can begin to use. And I think one of the things we can do as healthcare providers is assess these materials and say, okay, does this material that I'm about to hand to my patient or this person I'm interacting with make sense? Does it actually deliver the messages I want to deliver? Information portals, across the country, people are increasingly using portals for patients to get access to their own healthcare information. And how can we leverage that entryway into the healthcare system more effectively? Health educators and navigators to help people navigate through our complex system, interpreters, of course, and then the routine literacy assessments, which are now we're beginning to see happen much more frequently, but beginning to assess people's more capacity to understand information, whether it be a language capacity, whether it be a reading or numeracy capacity, or other capacities that are important to understand information. Provider training and communication. There are actually some tools out there and some campaigns that encourage patients and their families to ask questions of us more. I like this concept of Ask Me 3, which comes from the National Patient Safety Foundation. 3 good questions about your health. What's my main problem? What do I need to do? Why is it important for me to do this? Amazingly, when people come to us with a problem, they come to us often with a symptom, and then we're into a diagnosis phase, and then we kind of have some exchange of information. But the patient may actually not be equipped to step back and say, okay, now I need a broader understanding of what it is that's going on with me, and how do I address this? And then why is this important? What you're telling me to do, how does that fit in? I think that's a very nice heuristic for us to think about. But then we as providers also can be thinking about those 3 things and how we communicate to people. What's their main problem? And I should communicate that. What am I asking a patient or a family to do? And why is it important? And so I think when we're all aligned on thinking in that way, we can potentially have more effective healthcare communications and better prime patients to make effective decisions. And then there are other campaigns. Agency for Healthcare Research and Quality also has something called 10 Questions You Should Know. And so I encourage you to look into those. Those are publicly available. I'm going to give you an example of a project that I'm involved in as a researcher with a health system, Geisinger Health System, which is in central Pennsylvania, on helping patients with kidney disease make treatment choices. I started off with that patient case in the beginning of this patient who's had a crash start on dialysis. And in this, in my own work, a passion of mine is trying to help patients make better decisions about their treatment options for kidney disease. So I have a line of work that focuses on this. And just to refresh us, when people develop kidney failure, there are kind of 3 main categories of treatment for kidney failure: hemodialysis, peritoneal dialysis, or transplant, or conservative management, none of those treatments. And hemodialysis can be delivered in a center most frequently or at home. Peritoneal dialysis is more of a home-based treatment, and then transplant you can have a live kidney or a deceased donor kidney. And each of these processes actually are quite different. I've just listed for you, 5 different treatments here, and each one has its own narrative that a person would need to understand about. So quite a complex amount of information a patient would actually need to understand before entering kidney failure. Well, we have done multiple focus groups and work over the past to try to understand people's experience with making this decision. And so the quote I showed you in the beginning was one quote that had come out of that work. But over 20 to 30 focus groups we've actually done, patients and families have told us their experience with the health system when it comes to making a decision about kidney treatments. Patients have said they frequently start urgent dialysis. They have little time to make decisions they feel about their treatment option, poor awareness of alternative treatment options, and an inaccurate understanding of treatments. And family members they felt should be a part of this, but family members often felt like, family members themselves and patients felt like the families weren't adequately incorporated into the process. So I see this as kind of a system failure because this is a common occurrence and it continues to occur and it's multifactorial. Here's our 2 quotes, one from a patient, one from a family member, about them understanding treatment alternatives at the time they started hemodialysis. This patient says, quote, "I was vaguely aware of all the treatment options, but nobody in my medical team had talked to me. I was on my chair, my hemodialysis chair, one day on hemo, and the manager of the unit was nearby. He looked at me and said, 'You're having some trouble dealing with this, aren't you?' I said, 'Yeah.' He said, 'You ought to look at the peritoneal dialysis.' And that was the first I'd heard of it. So this patient had been on treatment and had never heard about the other treatment options. Family member said, 'At the time, I wish we could have been given more information at the time. But I was told that he just had to have it. He had to go on dialysis immediately. So I don't think it was enough time to get enough information to make a choice.'" What I'm bringing out here are compelling, and these are common themes. This is common. This is not just the most compelling. This is very, very common, these quotes. these issues point to how do we prepare patients, what kind of information do they need to have, and how far in advance do they need to have it, and who needs to have it, for everybody to be involved, so that when kidney function precipitously declines, people can kind of be aware and understand what's happening to them. And I think this kidney example is very similar to other examples we might see, for example, in other conditions like congestive heart failure or liver failure. There's several different other disease paradigms we could compare this to. Well, patients and families who've been through this kind of can tell us what they think other families should know about in advance. They say that they think other families should know about how treatments affect their morbidity and their mortality, their autonomy or their control over their own treatment schedule and the quality of their life, their symptoms, how a treatment is delivered and how frequent, how a treatment might affect their relationships or their psychological wellness, and their finances. And so in my own work, what we had done in trying to address those things that patient thinks others need to think about, we developed a video called Preparing for Kidney Treatment, and some books. And we spent years developing these video and books to be literacy and numeracy, meaning helping people understand numbers, tailored, as well as focused on some cultural considerations based on the population we were serving in the Mideast, on the Mid-Atlantic. So we developed these, and we were very proud, and we thought, okay, maybe at this time, this is years back, these materials we spent so much time developing could really help solve some of this health literacy problem that we're seeing. Maybe we can solve this problem by giving people these materials. And we set out, and so the materials this describes, the video shows 5 different patients, each talking about a different kind of treatment. One person has received a live kidney transplant, one person is on peritoneal dialysis, one person is receiving home hemodialysis, another person is in in-center hemodialysis, and another person is a family member of somebody who chose conservative treatment and did not choose one of those other treatment options, talking about pros and cons, risks and benefits. And so it's a nice video resource. There's also a book we had spent many years developing to be literacy and numeracy tailored, focused on we did reviews of the literature, comparing all of the different treatment options to give people information, the facts about what would happen if you chose this treatment versus that treatment, and putting it in plain language, helping people to understand the quality of the data that was there behind it. And it was a very long undertaking. It took years to develop this. And so we really wanted to test this out. But so we took this to patients. And we wanted to develop a research project where we would say, okay, we're going to see what happens when we give people this material, potentially through a patient portal, versus not giving giving patients material. And let's see what happens. Can we improve decision making? Can we improve health literacy? And we actually got involved with patients and their families at the start of this program. And we said, look, we have this. And they reviewed the materials and they said, oh, this is great. Thank you so much. This material is so valuable. But it's not enough. And this is a patient describing to us why they thought it's not enough in their own words. Patient says, so I think it's really important that the caregivers, and I'm talking about nursing, physicians, social workers, and all of the support staff needs to be able to educate you when you walk through the door. Say, that's what your diagnosis is. Patients really want all of us in our healthcare delivery to be aligned and around them to communicate what's going on with them. And people talked about really wanting to have more primers. Almost some patients and families talked about a Lamaze class for patients with kidney disease. Something that would help you learn and kind of mimic and go through and talk to peers about the experience and build up to this, so that there was a real reinforcement an understanding of what their condition was and a reinforcement of what they'd be asked to do and the choices they would need to make. So in that project, which is ongoing right now, as I said, with Geisinger Health System, we took this educational intervention, the video and the book, and embedded it into a whole health system organizational intervention designed to increase the whole health system's health literacy around kidney disease care. And so at the core of it is navigation and coordination, changing the healthcare team where there's now a care manager and a navigator focused on kidney disease who will help guide patients through multiple stages of disease, helping them get to education, psychosocial support, classes for self-management, involving their families and care partners, and self-care training. At the same time, this health system intervention also identifies what patients had told us is that they said, providers need to know who we are when we're early on in disease, and then they need to be prompted to start talking to us early enough so that we can be educated. And so behind all of these patient-oriented behavioral and psychosocial support, there's also changes to the electronic health record in the health system, so that there's a registry that identifies patients who've progressed in their disease to a certain point. And then when a patient has, and there's risk prediction modeling that goes in there, so that identifies who's at risk based on validated prediction models of progressing to kidney disease within 2 years, to prompt the team to know, hey, we need to start prepping this patient now, because sometime in the 2 years, it's highly likely they may progress. And also some flagging in our system, letting the team know that, hey, this patient now is at high risk to progress, and that we need to begin to huddle around this patient to make sure they have the services that they need. So what I'm trying to articulate to you is is that in my own work, I began to go from thinking about just the education and going into this larger system level model to improve health literacy. And I think this example is an example we can be using across healthcare, where we tend to focus in on individual problems, but thinking now more broadly about giving patients what they really need to get the care and make the decisions that they need to make. I'll mention here that there have been some key components that the Geisinger health system has been effective in moving forward that I think have made this program very successful so far. One is that from the very top of the organization, there's an engagement in this program and an investment in resources to help change the healthcare team, putting care managers and navigators right there embedded with the clinical care teams, creating a whole culture change where the entire system is ready and and willing to come together around this problem, developing registries, putting in risk prediction models, but also changing the healthcare team at the same time. A lot of work. And so you really need multiple groups within a system to be empowered to do that. And that, I think, starts with the top, but leadership within all these teams as well. And then focusing on vulnerable patient care transitions. And the concept that this is developed with the end user's input is very powerful. As I mentioned, again, we were thinking about, hey, we just want to deliver materials and embed them into our current system, and patients and family members really said, that's not only what we need. And so the idea that the system is ready to embrace that and make changes is very important. I just wanted to point out that we are measuring biomedical outcomes as part of our study, including the time it takes for people to get to dialysis and hospitalization rates. But we're also measuring some very different kinds of outcomes that I think are important outcomes for us to think about as healthcare providers, including how empowered do our patients feel? How many skills or how much self-efficacy do they have, the skills they have to carry out, they feel they have to carry out our recommendations? And how effective do they feel at their decision making? So a different way of thinking about a clinical outcome, not just in terms of the biomedical outcomes that we're accustomed to looking at, but also these more patient-centered outcomes that really, how is the care delivery from the perspective of the patient? And patients helped us design these outcomes. This is what patients think are important. Actually, when we talk to patients about how should we measure the effectiveness of this, the patients came up with the term control. I want to feel like I'm in control of my care. To try to break that down a little bit. But it just, really emphasizes that what patients are looking for from us as healthcare providers is not just to have their high blood pressure fixed or have their kidney disease treated. They want to feel like they have real power over their care. And the concept of organizational health literacy, I think, is something that can really help us accomplish that. So it is a daunting task, and do we have tools, and how do we measure progress? There are tools. There actually was a recent review of tools that was done as part of this Institute of Medicine program, and they've identified 2 measures assessing all of those 10 attributes of healthcare delivery models that I presented in the beginning. I want to focus in on this one by the Agency for Healthcare Research and Quality, because I think there's a lot of rich information there that no matter who you are in the healthcare system, you could actually use. And then also just touch briefly on this, the Enliven Organizational Health Literacy Self-Assessment Resource. So again, these are tools that help us, wherever we are in our healthcare system, think about health literacy and help us better improve the degree to which patients are able to make decisions that are aligned and act on decisions that align with their values. So the Agency for Healthcare Research and Quality has developed something called the Health Literacy Universal Precautions Toolkit. It's publicly available. You can get it on the website. And it focuses on 4 different aspects of our care that we can do to improve people's capacity to make decisions and understand their care. One is simplifying communication. One is confirming people's comprehension of what we're asking them to do. One is making the healthcare system easier to navigate. And then one is supporting patients' efforts to improve their health. And they've provided 21 tools that focus on the communication, empowerment, and support of systems. Here are the tools. You can read them online, but they include forming a team, and there's a lot of information behind each and every one of these. It's actually a very rich resource. I encourage you to go there. Creating a health literacy improvement plan, and this could happen at a systems level, but it could also happen at a clinic level. It can happen, even at an individual level. How are you going to work on this? I think at multiple levels. Raising awareness of health literacy, communicating clearly, using teach-back method with our individual patients, following up with patients, improving telephone access, conducting brown bag medicine reviews among ourselves to kind of talk about our effectiveness, addressing language differences, considering culture, customs, and beliefs, assessing, selecting, and creating easy-to-understand materials, using those materials effectively, welcoming patients and their families, encouraging questions, making action plans, helping people remember how to take their medicines, getting patient feedback, linking patients to non-medical support. So a lot of them we're talking about social determinants of health that really is not always within the healthcare sector. It's often within other sectors that we need to link them to, for example, social services. Directing patients to medicine resources, connecting them with literacy and math resources, and making referrals easy. So obviously, these 21 things cannot be done by one single person. It actually takes an entire system to do it. It gets overwhelming when you see the whole list, but we have to realize it's a teamwork that would allow this to happen. I want to give a couple of examples, concrete examples. So tool 4 is communicate clearly. And one of the recommendations, and even within these bullets, there's more information, but greeting patients warmly, making eye contact, listening carefully, using plain non-medical language. I gave that example of the local treatment, thinking about where what we're saying could be misinterpreted because we're thinking about it in one context and a patient may be thinking about it in another context. Using the patient's own words instead of, so we have a common language that we developed, understanding how patients understand things and speaking back in that same language, slowing down, limiting and repeating content, being specific and concrete with what we're recommending, showing graphics when at all possible without a whole lot of complicated numbers. And there are a lot of tools out there to help even with transmitting risk information now. You can go on to several websites to actually print out numerographs like I showed. If you want to show the percentage, you can actually show that visually in straightforward ways. There are a lot of tools online for that. Demonstrating for patients how something is done. So if they have to give themselves an injection, demonstrating that. Inviting patient participation, encouraging questions, and applying teach-back. Teach-back was mentioned a couple of times, and there's some key concepts with teach-back. This is the concept that you're going to ask somebody to tell you back what you just asked them, so you can make sure that they understand what you're saying. It's actually not a test of the patient's knowledge, it's a test of your own capacity to communicate with the patient effectively. So if they're not able to teach you back, it means you failed the test, so you've got to do it again. Chunking and checking, taking information into small chunks and then checking with people along the way, breaking it down into smaller pieces so they're not taking in 10 different things about your kidney function is progressing, and now you're going to have to think about treatment options. That's something that needs to be chunked and checked over time. Clarifying with people and checking again, using the show me method, as I said, show me, can you show me what you would do? And then using handouts that are appropriate along with these types of methods. And in this toolkit, there are myriad of videos and all kinds of examples. to use. Very valuable. They also have an assessment tool, and so this one is called the Primary Care Health Literacy Assessment. But what I like about it is you could see yourself using it as a team or as a clinic or as a group, and saying, how are we doing when we're saying we're addressing health literacy? So at the top, it says, okay, how does your practice do this? Doing well, needs improvement, not doing it, or not sure. And so, for example, our health literacy team meets regularly. Well, do you have one? Might be even a question. Is there even a health literacy team? Our practice regularly reassesses our health literacy environment and updates our health literacy improvement goals. Our practice has a written health literacy improvement plan and collects data to see if objectives are being met. All staff members have received health literacy education. All levels of practice staff have agreed to support changes and make it easier to navigate, understand, and use health information and services. And so these are ways where a whole team can be thinking about how are we doing about improving health literacy of our patients. We want to do it as individual providers, but also how do we do it as a team, as an organization? There's also another health literacy assessment resource that checks all 10 of those qualities of a health literate organization. This one's by Enliven, which is in Australia. It's an organization. And they basically encourage, these same checklists encourage team planning, responsibility, and timelines around creating a health literate organization. And so I won't go into much detail, but measuring competencies around those 10 qualities of a healthcare literate organization. So, you know, as I said, the task is daunting. This is obviously a very challenging thing to take on, and no one of us sitting in an individual chair can be fully responsible for all of this because it will take team effort. But the idea would be to get us aligned in our thinking about this, and all of us in our own ways contributing to this, and also, you know, helping collectively to move our organizations forward. I think the challenges are that there are many moving parts. You know, I've mentioned to you not only materials, but staffing, you know, hiring practices. So this is really very difficult, but something that we need to take on as healthcare organizations. It requires a tremendous amount of organizational commitment. This is probably not something that, you know, you start in 1 year and you say, okay, we did our health literacy campaign. This is something that takes 10, 20 years probably to really get going and getting well. So getting on board. It's something that might be somewhat difficult to measure. So I showed you these checklists. These checklists are measuring sort of culture change. How are we doing broadly? And so it requires a different kind of thinking about how we do things in addition to the technical capability that we have as clinicians in terms of delivering the actual care and making sure the patients get recommended the right treatments. It's a broader concept of how we're doing it. I gave you an example about kidney disease, and I'm sure there are examples throughout your health system and in other health systems on other individual diseases. But I think sometimes focusing on individual diseases or care processes may actually detract from the broad health system changes that are needed. A lot of the things that we're talking about may be things that have nothing to do with the disease, but have to do with the process. For example, how do we greet people at the front desk? That's a common universal thing that happens. How do we greet people when they come in our doors, whether they come in the hospital, whether they come in the clinic, whether they come, wherever they come in? Do we have standard practices that ensure that we're greeting people in the right way and giving them the information they need? And then another challenge is that our payment policies and other policies aren't yet completely fully aligned always to influence change. So we have to think about how to do this in the context of not always being fully incentivized to do it. We have other incentives as well. But the promise of thinking about health literacy at this level is that by embracing it, we will also be addressing some of our most pressing healthcare delivery issues, including safety and avoiding unforced errors, the quality of our care, fragmentation of our care, and giving patients what they need, truly giving them the kind of care that they want when they walk in the door. So I'm going to summarize here. I'm at the end. And I think the bigger picture things I've wanted to transmit are that health literacy requires more than just improving signs or language interpretation. It really is a global strategy to help patients navigate through our entire healthcare system. And it's not just one approach, it's multiple approaches. We need our full commitment of healthcare systems and the teams at every level to embrace this as a core value. And I think it's a call to action for us We all want to deliver the highest quality, best quality care. And we have tools now to begin to do it, but it really will take a lot of work on our part to see our part of this as more than just delivering one aspect of care, but thinking about the global picture. We can empower patients and families to improve outcomes at the same time. We have these frameworks. We just need to be able to put them into practice. And teams, and I think individuals at all levels of our organization and in every area of care can take part and lead the way. So I'm going to end there. I hope that leaves us with some inspiration. Obviously daunting. We've got a lot of work ahead of us, but I believe we can truly make improvements in our care through this approach. Thanks.
Thank you so much. I had a question sort of in your personal work and in studies done in this area. Where does the patient role come in, assessing their commitment also to their own education and health literacy?
That's a very good question. In my own work, we've increasingly engaged patients from the very start of these projects to begin to say, okay, where do you feel your role is? I don't think patients, we've done a good job of asking patients what they want their role to be and how they feel they can fit in. And so even us asking them would be a new paradigm shift. It would be a whole new way if we actually went to patients and said, hey, what are you looking for in this? How can I help you? What do you think is needed? Instead of we're always giving and kind of giving them from our perspective. We all are also patients and we have our own personal experiences, but again, we are very highly informed and very much in that system. Even when that happens, we're still often, as I said in my own case, ineffective. But I think we need to begin to go to patients and ask them, what do you need? How do you feel like this is going to help you be more empowered? Are there other things we can do? What do you feel your commitment should be to that? So I think that's an excellent point, and we're seeing movement toward that.
Thank you. Important to revisit decisions that have been made when the patient feels a lot better, for example, and of course when worse, but to add decisions can change according to your feeling. And the second thing, try to use the same words. People do not know that filtration rate is the same as kidney function, or creatinine is the same as kidney function, and so on. I mean, it is very difficult for them to realize that you talk about kidney function.
Yes, those are outstanding points. Number one, the first point being that people do make their decisions change all the time, right, based on the circumstances. So we have to check back with them. How are you feeling now? Now that you have additional information, now what are you thinking? And so that's critically important. Every human being, we're constantly reassessing what our decision is now that we've gone through this and we know more. This concept of how we communicate and the different words we use for one thing, like kidney function, is really important for us to keep in mind throughout clinical care. You know, as a clinician, we're talking about a lab value, we're talking about a physiologic process, and then we're saying an organ, you know, and we're using all these same terms to talk about something that in the patient's eyes, they want to say kidney function, okay, and they need to learn what a kidney actually does. So really boiling it down to a different kind of terminology, speaking the same language and being cognizant of how we take all that we know and boil it down into plain terms.
When we think about the area of emotional intelligence, we hear about that on social media, and we try to develop as being competent human beings with our friends and family. But I think we can use that in healthcare as well, in the sense that for emotional intelligence in real life, we depend on processing out here. We depend on a feedback loop. I say something, I see how your face looks in reaction, then you say something back, then we clarify, then we create a new reality together out here in the middle. And I think in healthcare, we could do that better, where we provide an ongoing feedback loop of understanding as opposed to just a couple of points of information going, you know, we elicit, we get information about symptoms. if we're doing our job right, we say, well, what is your personal goal for yourself? What pathway should we even be on for treatment for you? So we're eliciting information from our patient, and we kind of put that down at the beginning, and then we get information and we give back a diagnosis and we start a treatment plan and we say how to do it. But that ongoing loop of figuring out how to keep processing together, I think your point about the whole team being involved in navigating, being aware of the patient's diagnosis, being ready to hear that there are more questions, that we got to this level of competence, in taking care of ourselves, but now we're ready for another step.
Yeah.
That's a good paradigm, I think, for healthcare too.
Yeah, I would agree. What you articulate is very complex, but I agree that this common, this is a continuous process. So it's not just a single interaction that's going to be job done. It's an ongoing understanding, okay? You tell me what your goals are, what your symptoms are. I then understand what's important to you. Now I'm going to give you information that is relevant to what's important. That's an evolving thing. What's changing, what's important is constantly changing. And I may not even be the only resource to address that. Others need to come in. So it's this concept of constantly reassessing and appropriately providing information that's relevant and understandable, and this shared understanding that's between us. And it's at an organizational level. I think we can work out on it as individual providers, but then as a system as well, we can be coming in and augmenting that.
Thank you for a wonderful talk. I'm on the board of the Northwest Kidney Centers up here. I'm not a nephrologist. And they have several patients on the board, people with ongoing hemodialysis, peritoneal dialysis, transplant patients. The patients are very much engaged in the Northwest Kidney Center in terms of directing its activities. They've also developed the Choices class. And the Choices class is what you're talking about. So before you get to end-stage kidney disease, you have an educational program, and they actually do it at Harborview, our county hospital. And the outcome is that if you take the Choices class, you are much less likely to start dialysis with a tunneled line. You don't have a crash start like the patient that you described in your vignette. So I think, and having heard your talk, I think we'll go back and think about these things a lot more, about how we can even more effectively communicate to our pre-dialysis population. So thank you very much.
Thank you. That's wonderful to hear. I know that there are a lot of leading efforts happening here as well as elsewhere in the country, and I think that exactly that patient voice really brings a lot to it, because this is who's gone through it and experienced it and knows best. They are actually the experts as to what it's like to go through this and how to help people avoid these crash starts.
Thank you for a great talk. I just had thoughts, as a resident, and in terms of curricular changes that you would suggest at the medical student or graduate medical education level, in terms of even teaching physicians or future physicians and as leaders and as I feel like that would also be another audience that is a really powerful source in terms of teaching us to be aware of these challenges in health literacy, and to have us become powerful communicators and teachers, and to then as future providers be part of that effort and change. So I don't know if there are things that are happening at Duke at the curricular level to encourage these coursework in terms of educating us as teachers and providing us that framework, or if you have suggestions for that.
And so I certainly couldn't speak for all of Duke, and I'm sure I'm not aware of all the different activities happening on this level. But some activities that I've seen have been, for example, getting medical students out into patients' homes, so that they can actually go into the home of a patient that's got multiple issues going on and really be in that environment, bond with those patients, and actually do a continuous learning so that they're learning about what it takes for that patient to get health care. I think one of the challenges in our medical education is that as learners, we start so young. We ourselves often have had very little interaction with healthcare and have very little understanding of what it means to be sick. And even our family members in the head may not have gotten sick, or have experienced that. And so somehow getting our younger learners into environments where they can develop empathy and understanding of what it means to actually get care is a critical component. And I think we're all starting to see more and more of this being built into our educational approach. But the more we can kind of develop that sense of, this person I'm seeing could actually be my own grandmother, or this could be me in a number of years. That link, that tie, that understanding the human element is so critically important to build in early. And I think while we're trying to process a lot of information about how to treat disease and what disease is, et cetera, how we think about the whole person, that kind of additional curriculum is important. I'm seeing it grow in lots of different ways, but I don't have any magic bullet. I'm sure folks here probably have also a lot of understanding of that. But I think the more we can build in that experience that goes beyond your actual delivery of care as a doctor with a white coat on, and more to sitting next to the patient and kind of understanding what it's like to actually go through this system and get care, the more that we'll also be potentially capable of communicating appropriately.
Well, thank you very much, Dr. Boulware.